Another interesting point is the role of minimally invasive surgery. As thoracic surgeons, we've moved very much away from open surgery where absolutely possible. However, now there have been lots of discussions, both Dr. Mercer probably knows well from the colorectal group, as well as amongst cardiothoracics, on minimizing the use of laparoscopic procedures or VAT surgery, and then taking that one step further, robotic surgery. So perhaps, Tom, do you want to sort of tell us a little bit about what you guys are doing from a minimal access perspective?
Yeah. So, we're very aware of the guidance and the reason behind the guidance, although I'm not sure whether there's been any evidence or whether it's just an upfront concern about aerosolization. For thoracic surgery, so most minimally invasive surgery in thoracic surgery doesn't involve CO2 insufflation. And so my understanding is it's the high pressure CO2 insufflation that generates the aerosol around the ports. So for that reason, I would think probably a VATS, a conventional non-CO2 minimally invasive approach in thoracic surgery, is probably pretty safe, maybe even safer than an open approach, because you have less lung flapping around in the air and more of the virus, around the lung being kept inside the chest. So I see no reason to be concerned up front about a VATS non-CO2 insufflating approach to chest surgery. What's clear is that we need to make whatever surgery we're doing extra safe, because we don't have the normal safety net of critical care if there's a major intraoperative bleed. So our operational plan is that we have no problem with people doing straightforward cases by non-CO2 VATS. But if we feel we're heading into dangerous vascular injury territory, we should open to keep it safe, because a major bleed and blood transfusion and ITU backup just probably isn't available or a good idea. Robotic surgery, the way most people carry it out, does involve CO2 insufflation of the thorax. My view is that there's probably no role for robotic surgery at the moment. It's usually for small early stage tumours, and I think those patients would be better off with a deferred approach to surgery in 2 or 3 months' time. And CO2 aerosolization within the chest cavity has got to be even more dangerous within the abdomen, because presumably there's a lot more virus on the visceral pleural surface than there is on the surface of the bowel. So I think any operative approach to the chest that involves CO2 insufflation is a bad idea at the moment. Obviously, there is no evidence to back any of this up.
Thank you. Alberto, what's been going on in Italy from this perspective?
The minimally invasive, you mean? Yeah. So basically, we carry out our operations in minimally invasive surgery, but without CO2 in most of the centers, I would say. And even there are very few centers using robotics with CO2. So as Mr. Routledge said, there's no evidence of what problems can CO2 produce at the level of the pleura, but certainly not using CO2 doesn't make a difference, and still we are doing something safe and good for the patient. Of course, given these problems, shortage of ICU beds, actually we don't have ICU beds at all, I would say, right now. And the fact that it may take a little longer for bigger lesions or N1/N2 disease, those cases are carried out in open. We are quick and fast in order to make sure that the procedure is safe and lasts as little as possible, as shortly as possible.
Thank you. Dr. Mercer, from a collaborative perspective, you've obviously seen what's been going on with other specialties. Is there anything else we can learn from that?
I lost part of what you said there. I saw your lips moving, but nothing else.
From a collaborative perspective, do you think there are things that we can learn as a specialty from our other colleagues?
Well, I think all of the people doing laparoscopic surgery had slightly different parameters, but as you were saying, if you're not using CO2 insufflation, it's not such a major problem. but they've had, you know, the gynecologists have had an explosive detonation of the uterus out of the vagina in some cases, when they haven't deflated the abdomen properly. So everyone's saying if you do have to do laparoscopy and you do insufflate, then you have to release the pressure very slowly on it. I think more of an issue for you guys is what you do with the hoods and the numbers of air changes that you've got. That's probably more of a risk for thoracic and for ENT, because of the viral load that comes with having the hoods on and when you turn the hood off before you open the doors of the theatre. But it sounds, if you're not using CO2, then it's not such a major problem as some of the other people are having. But essentially, a lot of people have stopped doing laparoscopy at the moment.
Certainly the Guy's Hospital abdominal surgical view seems to be that to keep the use of CO2 insufflation surgery to an absolute minimum. So there are some cases where the surgeons feel the benefit to the patient of a laparoscopic approach versus an open approach is so enormous that it's worth essentially placing the staff at increased risk in order to do the patient, to provide better treatment for the patient, which is always a very difficult trade-off under these circumstances. But if the benefit to the patient is more moderate, then they are trying to avoid a laparoscopic approach.
From our point of view specifically, there is this habit of testing the stump after the lobectomy is performed, or assessing whether the inflation of the remaining lobe is good enough. And sometimes with pleural scars or the pleura not being completely, you've been rough sometimes with the staplers, you may have some air leak. So that's actually the point where the most dangerous aspect of the surgery, in thoracic surgery, may happen, because that's where the viral spread through aerosolization can happen. And probably the minimally invasive approach actually contains it inside the chest rather than spreading it around through a thoracotomy.
I think there is something to be said for that being the case. The other thing, although I'm not often a fan of expensive and unproven adjuncts, I think anything that you can use to minimize postoperative air leak, sealants or topical patches that you place on suture lines or raw parenchyma to minimize postoperative air leak, both for the operative team and also for the ward team afterwards. I think quick surgery is good, and surgery that absolutely minimises air leak. Both of these things are true under normal circumstances, but they are particularly true now. And I think money spent on adjuncts and sealants to reduce air leak is probably money well spent at the moment.
Absolutely.
Another thing, when finishing procedures, Tom, have you changed the practice of drain connection and things like this? Because usually we put a drain in, leave it, and then connect it when everyone's got the kit ready. So presumably you want to connect the drain as early as possible before the lungs expand.
Yeah, absolutely. We connect the drain as early as possible. And we place it on suction in the operating room if we're using an underwater seal, so that and we do that before closing the chest, so that as soon as air starts being forced out through the drain, it's going into the wall suction rather than just into the operating theatre environment. And I think little things like that can potentially make a big difference to staff exposure. The other operational thing we've changed is we are being much less excited about lymph node removal. There's a fairly universal view that at the moment adjuvant chemotherapy for node positive lung cancer is probably not in anybody's interests. And while the added morbidity of a lymph node harvesting at the end of an operation is not huge, it does take longer, and a longer operation is more exposure of staff, and it does increase the risk of postoperative bleeding and length of stay modestly. And if it's not going to change the patient's treatment at all, then I'm not sure that extensive, maybe remove the lymph nodes that are in the way, and certainly remove the ones that are clearly involved. But I think the risk benefits for everybody, patient and staff, of a radical lymphadenectomy probably don't justify it at the moment.
And actually, have you changed the breakdown of procedures that you're doing? So things like mesothelioma surgery, for example, procedures that would generate huge air leaks as a matter of normality, are we doing less of those?
So mesothelioma surgery at the moment in London is only really carried out as part of the Mars multimodality study. our view at the moment is that we have no business doing experimental cancer operations that have a large post-operative requirement for ITU, usually for several days, even when things go well, and render patients probably extremely vulnerable to viral pneumonia with no proven benefit. And as you say, a large air leak and therefore considerable staff risk as well. We think for all of those reasons, there is no reason to be carrying out that sort of operation at all at the moment. So we have withdrawn entirely from radical mesothelioma surgery until the situation changes considerably. We're really focusing on operating on bulkier tumours in fitter patients, the kind of patient who will do really badly if you send them away and say come back in July, probably it'll be too late to help them by then. And the kind of patient that you're reasonably confident you can get out of hospital in 3 or 4 days without recourse to ITU. So it's a much more restricted practice than we were offering a month ago.
Prof. Neville, have you changed your practice in ENT in a similar fashion?
I can't think of too many examples in that sense, because any drains and things like that we do in the neck are not directly connected to the airway. So no, I don't think there's any major impacts in what you all have just been discussing as far as ENT is concerned, at least not that I can think of immediately.
Can I ask you, are you routinely testing patients for coronavirus in advance of offering them cancer surgery, or are you offering anybody who's asymptomatic? Our practice is to try very hard not to operate on somebody who is, developing viral pneumonia. So we're nasal swabbing and currently X-raying everybody a day or two before surgery. And some of my colleagues are thinking about CTing them a day or two before surgery to make sure they don't have, classic CT evidence of asymptomatic viral infection. Are you doing the same thing, or do you just not have the resources to do that?
Well, we try to do it. We don't have the resources for all the patients. So basically, yes, X-rays. We actually admit the patients a few days before the operation itself in a sort of isolation, so that they will not get interaction with people who may be asymptomatic. We do test them if we suspect they have symptoms. As an example, the other day, a patient who actually had atelectasis of the lower lobe due to a bulky lesion, hilar lesion of the left lung, developed fever, and she was supposed to have surgery the same day. We were not allowed to take her to theater. We had her tested, isolated, chest X-ray, rescan, and then fortunately the test was negative, and we could carry on the operation the next day. But that's what we are doing as well.
Okay, thank you. Another aspect of practice that's changed a lot for us is the consent process. I can't quote the data, but I heard there's some data coming out of Asia that the perioperative mortality for lung resection at the moment is significantly higher, maybe as high as 10% or more. And I think you need to have a very different conversation with patients having elective cancer surgery than you would have had a month ago. Even if they're fit and well and you're operating in a clean environment with a clean team, clearly there is a risk of them, suffering severe respiratory failure in not just the inpatient phase, but in the weeks following surgery as well. And we're very clear to be honest about that as well. And that's, changes some patients' view on whether they want surgery.
Yeah, that's the same for us as well. We have a routine multidisciplinary in this context. So if we understand that we are not able to operate in due time, the patient, and the tumor is actually big, and the patient can't wait, either we refer the patient to another center, or we talk very clearly and with the risks and benefits. Of course, our situation is probably a bit different from what you're facing right now, because we run very few lists a week, and due to shortage of equipment, of medical staff, of nurses, so it's very, very difficult. We are trying to operate in other centers as well. Our management is trying to figure out whether there is an opportunity to operate in other hospitals which are COVID-free, because unfortunately or fortunately, this hospital has become a COVID hospital. So everything is actually rearranged to accommodate all the COVID patients needing ICU and critical care units as well. So our situation is probably worse, and this actually is reflecting on the care we give to the patients. So I think, as you said, being very clear on the outcomes, the risks, benefits, and if possible, wait or delay the operation that's in the patient interest, but in our interest as well.
Well, I think you highlight one of the most difficult things for us as surgeons during the current situation is not being able to provide the high level of surgical care that we're used to being able to providing, and having to settle for offering what we know is less good care for a lot of our patients, which is a hard thing to have to live with.
Yeah, I agree with that, especially for stage 1A tumors, for example, very small nodules. Some of these patients have been referred to SBRT, although we know that probably a lobectomy or a segmentectomy would do better for the patient. Still, this is a crisis period, so we have to deal with what we have and in the interest of the patient. After all, of course, the patient has to be informed and agree on this, and we really talk a lot with them nowadays, even more than what we used to do before.
Yes, yeah, I agree. Absolutely. Can I ask you? So you alluded to the need for hospitals to work together, and one hospital may have capacity to operate, whereas another may not. Do you have good systems in place for allowing that cooperation and that sharing of cases between different hospitals? Hospitals are rivals.
That's very true. It's a very good question. So, for example, I know in Lombardia, that's the area around Milan, that most of the thoracic surgery units have shut down, and there are just 2 big oncological centers performing the surgeries. Here in Piemonte, where Torino is, where I work, things are a bit different. There are major hospitals which can still carry on the operations, and they don't need support. Us being COVID center are actually different. It's completely different, and we need support for operating. And the management is actually doing good because trying to find whether there is an opportunity to operate in other hospitals, but that's a big problem and a big issue because the other hospital is likely to be COVID-free, and so they want everybody to be tested. This means increasing the number of tests, which is not easy. All the patients should be tested, and then it's difficult for us to look after the patient after the operation. There is a lot of, as you can understand, cost effectiveness on this as well, because you need to transport the patient back to your ward after the operation, maybe 1 or 2 days later, the operation takes place. So it's a very, very complex thing. And we have also private structures which have been transformed into COVID centers for obviously asymptomatic or mildly symptomatic patients. This is helping, but it's very complex. So unfortunately, I believe that if the situation is not going to change in a short period of time, then we will have to refer the patient to other colleagues, which is something which you would never like to do, but you have to in this case.
Yes.
Can I just ask, Dr. Mercer, from a interspecialty kind of collaborative perspective, Tom raised the point about consent process, shared decision making with the patients, and that seems something that the kind of colleges together should really be coming up with a plan, a protocol for how we manage these patients preoperatively, what we say to the patients, and also what our protocols are with regards to screening. So if we can't test them, do we make them self-isolate for 7 days before they come to hospital? Do we CT them? What was your thought on that?
Start with the testing, first of all, I mean, we have completely inadequate testing in the United Kingdom at the moment for a variety of reasons, which remain opaque. So testing is probably not going to be an option. And we have to bear in mind that within, Italy are 2 weeks ahead of us. And so if you have 80% penetrance of the virus by now, probably in Italy, 70% or so of the population are COVID positive anyway. So I think our advice nationally is now assume every patient is COVID positive. In our Zoom meeting last night, the current president of the Society of Cardiothoracic Surgeons was saying they had he's a cardiac surgeon, he had 2 patients to operate on the day before yesterday who needed scans for other reasons and were fit and healthy and well, and they had COVID changes in their lungs. And actually they went ahead and explained to the patient that the situation, I presume they both had critical coronary problems, and they went ahead and did the operation because they felt there was no other way, they couldn't stent them, and the patient understood the level of additional risk they were taking. So certainly in terms of consent, that discussion, we talked about that as well, and that needs to be documented, if probably with 2 consultants there, because medical legally there's going to be a minefield afterwards. And so change to current practice. NERML has been at the forefront of providing me information, and in the last 2 days we've done the prioritization of all procedures, both adult and pediatric. The adult one has gone to an HSC and is out in draft form already, and that will give surgeons a baseline to say, well, I'm sorry, but we can't do this operation within these particular timeframes, and therefore there will be a sort of a blanket, if you like, of protection there. But certainly if you're dealing with cancers and there's another way of treating them, as Tom has said and Dr. Sandry said, then some patients will have to be put down an alternative pathway. And we know that will almost certainly mean they end up with less than appropriate care. So that's a battle for us to have later. In terms of transfer, part of the work that I've been doing is looking at the routine cancer care that's going to be provided in most hospitals, and all hospitals will be COVID positive by the end of this process. So I don't think that any will be negative. And there are mutterings about super cancer centres, as you just, Dr. Sandry's alluded to in Lombardy. That will probably happen in the UK, and it looks like the centres will probably be, and this is pure conjecture, please don't put any weight on this, but probably the Marsden, probably the Christie, and probably one in Birmingham. I'd have thought for England, Scotland and Northern Ireland, Wales, we have to wait and see about. And therefore there will have to be criteria by which people are transferred to those centres, and that will come down to survivability of the tumour as opposed to anything else. And it's going to be brutal, just brutal.
Yeah, and I think a lot of my colleagues are anxious about possible fallout from this decision-making process once the dust settles on all of this, because those decision-making processes still have a bit of an edge of chaos or lack of central coordination to them. And yet we're having to make these decisions day by day, and it'll take some time to get a sort of centralised, fair and transparent process in place for them.
Yes, I think it'd be interesting to know from Dr. Sandry, have you had a sort of centralised command structure brought in Italy to deal with this? Because at the moment in the United Kingdom, we have lots of people rushing around in the NHS England, the Department of Health and Social Care, waving clipboards and doing ridiculous things. No one's taking control.
Well, something like that is happening in Italy as well. So we have, of course, the Higher Institute of Health, which is giving guidelines on how to deal with what we should do. But then again, our health system is such that every region has a possibility of deciding and making, of course, a decision on what is best for the population of that area. As an example, there have been a lot of different ways of dealing with the tests in Lombardia versus Veneto versus Piemonte or other regions of Italy. And although there has been an indication from the Higher Institute of Health, this is actually decided on regional manner, and therefore there are different ways of dealing with the same thing. And on a lower level, this reflects on the hospitals too, and referrals for cancer patients or elective patients, as an example. That's what's happening in Italy. So
Okay.
there's some chaos as well here.
Okay, very helpful. And just to come back on Tom's point about the legal repercussions afterwards, certainly within the United Kingdom, the law changed in 1977, so that the Secretary of State has to promote a comprehensive health service, but it has to be done in the context of the state of the nation at the time. So the fact that we can provide less appropriate care, we can't provide the care we would have provided a month ago, is covered by case law and by statute. And so it's highly unlikely that any patient would be able to come back and say, a month ago you'd have given me this, but now I've got the following care. It would not get to judicial review. The courts would, I think, almost certainly throw it out. There probably would be one or two test cases, but please don't think that there's going to be lawyers chasing this afterwards. There is very good case law that backs up the fact we can only provide what we can provide.
That's very helpful to know. Thank you. I hoped that was the case, but didn't know the specifics. But I've been surprised by the level of senior organisational paralysis sometimes, and I think it's concerns of that nature that are sometimes driving it.
It'll be interesting to see if that will be the same for our American colleagues who'll be watching this as well. So watch this space.
Our American colleagues, seeing as we have a centralised healthcare system, we'd be very good and agile at setting up centralised decision-making processes, but that's dramatically not the case. Whereas fractionated and rivalrous as anybody else.
Well, the National Cancer Director, there's a few queries on a piece of paper that I've just circulated to the specialty associations, but the National Cancer Director wants the information about the cancer prioritisation. He wants it tonight. I've just received an email that he wants that back straight away. So there will be a framework probably within the next 24 hours or so for that.
So I'm conscious of time. Just a couple of things to wrap up really. First of all, the one thing I wanted to ask was, Alberto, from being a few weeks ahead of us, if there are a couple of pieces of advice that you could give us, or one piece of advice that you could give us to try and improve the situation for us in 2 weeks' time, what would it be?
Well, there's a lot to say in this. So basically, I think one of the mistakes, if we can call it as a mistake, we did was to chase the virus rather than being ahead of it. And this is actually what probably can happen in other countries around Europe. What we actually are quite concerned right now is how to make sure that we don't get into what's called second wave of pandemic. And so once we overcome this, then we will have to make sure that what we learned and will be just put into practice. And probably there might be some new things which can be thought of. And by saying this, I mean testing more patients, more people, make sure that PPEs are available for all the hospitals I mean, we need PPEs. I mean, here in Italy, the supply has been very short lately, and increasing the infection rate amongst doctors. And we counted around 55 deaths of, first-line doctors affected by COVID virus. Self-quarantine is actually very, very, very important, and it's something which, according to the Lombardia thought, and I think it's something appreciable, we need technology to support us. We are developing an app right now which might, I think it will help us to make sure that we have a control over the infection and the symptoms of the patients who are self-isolated at home, checking on their health status. And probably one thing which one of the regions in Italy is actually doing very well, which is Emilia-Romagna, is increasing the resources for community-based care, meaning all those patients who have mild symptoms and don't require hospitalization are followed up physically by somebody who knocks at their door and sees how they are, checks on their health on regular basis. So these are small things, but actually make a big, big difference.
Thank you. So I think we've been going on for some time now, so unless anyone else has got any burning comments, I think we'll probably wrap it up there. Any last suggestions from anyone?
Well, thank you. That has been very, very useful, and I think learning from our counterparts in Italy has been very, very helpful. So thank you. I hope we don't follow you completely. We will learn from your experience.
I hope so.
Thank you, Richard. That's been very helpful for me as well, and some very useful points which I'll be spreading nationally. Thank you very much indeed. Much appreciated.
Thank you very much for everyone for taking part, and stay safe. Thanks.
Thank you. Take care. Good day.